a little bit after 3 p.m. Eastern Time, noon on the Pacific Coast. And we're joined today for a conversation with a newer face to some of you in the HCM community. And this is Dr. Ahmad, I'm going to mispronounce your last name again with that R, Masri. Close enough. You'll fix me. And we're going to talk about a couple of things today. Number one, the changes at Oregon Health Science in Portland, Oregon, and little COVID, what's going on today. And we're going to discuss how a physician has chosen a path of being involved in an HCM Center of Excellence, but really strategically planning out a career. Welcome to the program.
Thank you. Thanks for having me.
We're really happy to have you today. So let's start off with what's going on at Oregon Health Science and what is your new role there?
Yeah, so, I joined OHSU back in last summer. I joined the Hypertrophic Cardiomyopathy and Amyloidosis programs to work alongside Stephen Heitner, who many of you know, with the idea that, we wanted to continue to expand, our program and accessibility for patients, not having long wait times, and continue essentially to provide, our services in a timely fashion for the whole state and also the neighboring states too. And, over the last couple of months, that role has changed since Dr. Heitner essentially, decided to move from OHSU. And so right now I took over essentially for directing the Center for Hypertrophic Cardiomyopathy and Amyloidosis. And, we continue essentially to provide our modified services at the times of COVID, but with the same goals and same plans as ever before, is to continue to expand our program and services and continue to provide essentially excellent care for all of our patients who are affected by these conditions.
So we'll pause, and as everybody can see, if you're watching this at a later date, we are still in COVID quarantine, as you can see up in the corner. So we're going to discuss a little bit about what is going on from a procedural point of view for patients with HCM during COVID times. Are you doing telemedicine services, phone-ins? Are they coming into clinic? What's going on in your program right now?
All right, excellent question. So we actually we started early in our mitigation efforts in order to decrease the transmission or the potential transmission essentially of COVID. And so starting early March, there were a lot of changes in our healthcare system where we essentially did a gradual rollout of changing in operations and the way we administer things. And so for essentially clinic patients, what we have done is we, for example, in my clinic, me as the physician, I would go over all of my list of patients and decide essentially which patients still should be seen in person versus essentially doing virtual visits or phone visits if they're unable to do virtual visits. And so we were able essentially to switch about 95% of our visits to virtual/phone visits. However, there are some new referrals where the question is, does the patient have HCM or not? And you need to do a lot of imaging and a lot of testing to know that. So these kind of referrals, we've been doing them on as basis, as they come. We either decide to delay it for like 2-3 months of evaluation if they're doing okay. If they're having a lot of symptoms, we figure out a way of doing that. And also to accommodate our patients, we modified all of our operations in the clinic. Our clinic is not connected to the hospital. It's actually far from the hospital. And so we also essentially minimized the amount of waiting time in the lobby. We separated essentially patients, and we're doing all of their echocardiograms and whatnot on site at the clinic so that they don't have to go to the hospital or travel and do things like that. So we try to modify our operations in order to, one, keep patients at home as much as we can, and two, essentially, if they have to be seen, that essentially there is minimal interaction with everybody except for the physician and maybe the sonographer and an assistant, a medical assistant. In terms of procedures...
No, go ahead.
Yeah, in terms of procedures, essentially, we view septal myectomy as well as alcohol septal ablation as somewhat time-sensitive but semi-elective procedures. And because of the need to stay in the hospital for many days after, typically 3 days total for alcohol septal ablation, 5 days total for septal myectomy, and some of these days would be in the ICU, we elected to defer all of these procedures for the time being. And as of now, essentially, we are giving appointments, late May, early April, but we are playing it a week by week basis and changing as the situation changes.
That's good to know. So you guys have a little bit of a jump on the rest of the country because COVID kind of hit the Pacific Northwest first. So you have this well under control, and you've been operating this way for over a month now, right?
Actually, more than a month. I actually looked at the timeline, maybe a week or two ago. The first email that we got that we were not allowed to travel even for business travel was essentially in early March. And then from then, day by day, there were essentially changes happening on daily basis. And, we switched our clinics essentially a little bit more than a month ago, probably 5 weeks ago. We switched all of our clinics and operations.
Fantastic. So those of you who are in touch with the HCMA, you may have ever heard our tagline that we serve the HCM spectrum disorder community. And part of the reason we say that is a lot of people come to their ultimate diagnosis through HCM because they're seen to have a thickened abnormal heart muscle. But there are a lot of different genetic reasons why HCM might appear in the heart. And very few physicians today have formalized training down a pathway that helps them delineate between which of the HCM spectrum disorders might be affecting you. So would you first tell us what some of the spectrum disorders are that you specialize in? And then we're going to dump into this training and how did you get on this HCM heavy path that's going to serve our community really well in the future?
All right. So we'll start essentially with your first question about HCM spectrum. So, the way we tell people essentially the referrals that we take, we don't tell others that we take referrals for HCM only. We say any condition that you think that the heart is thickened, out of proportion to what's happening or what's going on. For example, hypertension leads to thickening of the heart, but it presents a bit differently. In some minority population, it actually presents as if it's HCM. And so we do take all these patients. And so the common thing in these patients, if they don't have family history or if they don't have known history of the disease, is they present because they were found to have some thickening in the heart muscle or some obstructive state, inside the heart, there is some obstruction that is shown on echo. And, the spectrum ends up being, hypertrophic cardiomyopathy. Simply hypertension can also cause that. In elderly patients, the right circumstances of essentially maybe dehydration and as well as some thickening from long-standing hypertension can also lead to that. Then we have essentially cardiac amyloidosis. In a little bit on the early stages, it can actually sometimes look like HCM, especially the non-obstructive type. Even with obstruction, you can still have amyloid, but sometimes, that's actually more on the rare spectrum. But the common one is just similar to an obstructive HCM. And then you have, the one that is essentially rare, but essentially well-known because we have a treatment for is Fabry disease. And the nice thing about Fabry nowadays is that we can diagnose it with imaging. And so that's why essentially it is way more recognized nowadays, similar to HCM, but it's on its own spectrum because it's on the rare side.
And then in the kids, which you treat adults, there are other disorders that can be part of syndromes that can have an HCM-like presentation. And that's why, HCMA can't just circumuric mutation HCM. We are looking to help everybody find the right pathway to care when they have these thickened heart muscles. So the thing I find intriguing about you is your training really is very specific to HCM. And I'm considering you our next gen doctors because there are these big programs now that you can get really detailed training in and not just one place. So tell us, you're in med school, you get out of med school, you're going to go into residency, you pick cardiology, then who steps into your path and changes things?
Yeah. Excellent, point there. I was lucky because I met, an HCM cardiologist. His name is Melan Desai in Cleveland Clinic. I met him when I was a medical student. And then, I approached him back, and said, look, I have a couple of months to kill before starting my residency training in internal medicine. Can I join your team, and do essentially cardiac imaging research? And he said yes. And so I joined his team, and I started doing cardiac imaging research and focusing mainly on, hypertrophic cardiomyopathy, as well as other cardiomyopathies such as radiation-induced and, and Fabry disease. And so, and that's essentially who introduced me to HCM, Milan Desai. And, from there, essentially, I started developing this interest in such a common condition that is underdiagnosed, that essentially gets overlooked sometimes for years before actually the right diagnosis is achieved. As well as, growing up, we were always intrigued by, the famous, essentially, especially in sports, famous individuals who had HCM. And so, putting it together, I was lucky to meet Milan Desai, but then, he put me on that path where I started essentially learning about HCM, doing research in HCM, and, I learned echo, I learned MRI, in relation to HCM. And then I finished my residency in Cleveland, and then I moved to the University of Pittsburgh to do a cardiology fellowship. And to your listeners, essentially, this is where you get specialized training in cardiovascular diseases in general. And within cardiology, there are 5-6 subspecialties that you can do. With the idea that I want to do HCM and other, diseases like HCM, kind of cardiomyopathy specific training, I designed my training to evolve around the imaging modalities that actually pertain to this disease. So I specialized in echocardiography and in cardiac MRI, as well as nuclear cardiology, because nuclear cardiology is an important tool nowadays to differentiate cardiac amyloidosis from HCM and other disorders. And then at the same time, I met Timothy Wong, who is our hypertrophic cardiomyopathy specialist in Western Pennsylvania. And for those of you who don't know Timothy, he is a great individual, a great physician, and he would pull you to HCM even if you didn't want to do it. And so I joined him. I joined his clinic, and I worked with him on research projects, and seeing patients. And it was really a lot of fun, being exposed to a different population than the one I've seen in Cleveland. Because as you can imagine, Cleveland is a combination of a community and referral base essentially for HCM, while in Pennsylvania there is a lot of families, big families that are affected by the condition, and you start diving more into the genetic aspects of things. And so, I designed all of my training in Pittsburgh around HCM, amyloid, and similar conditions. And then and then I did also more research. I did a master's degree there, all with the idea that, I want to continue my path as a physician researcher in HCM and cardiomyopathies. And then I got, I met Stephen Heitner, in some of these scientific meetings, American Heart Association, American College of Cardiology. And as you know, Steve was one of the pioneers in our, the newer treatments that we have for hypertrophic cardiomyopathy, such as mavacamten. And I met him, and after some of his presentations, and we hit it off. We actually have really similar personalities. The difference is, as I told you before, I have more hair than Steve, and I'm a little bigger than him in size. So. And so, we hit it off, and I decided to join him at OHSU, where we essentially, he's done a great job. We have, we have a fully multidisciplinary program where we cover essentially HCM from birth until essentially, late adulthood, from imaging all the way to genetics. And we are heavily involved in research and clinical trials, and we plan to continue to doing all these activities and continue to be, better in serving our patients, and and try to, stay on the mission that we're here to serve the patients with hypertrophic cardiomyopathy.
So the amazing thing to me is we have now 40 centers of excellence, soon to be 42. Stay tuned for more information. And you pick 3 of the stronger programs in the United States. You tag in with Cleveland Clinic Milan Desai, who we'll be talking to next week right here on Facebook, or next week or the week after. Check the itinerary. And then you go over to Timothy Wong, who has a great program that we've been working with for over a decade. And then you go out to Oregon. So you've got this really deep breadth of knowledge, but you also have a network. When something stumps you, you have some of the greatest minds in HCM that you can reach out to and say, hey, I've got something unique here. And having those relationships and that collaboration and that training is just phenomenal for the patients in your region. So I know some patients really had a connection with Dr. Heitner, and the fact that he will be leaving the program at some point is hard for them. But I want them to know that they're in fantastic hands with your leadership there. I truly believe that. If I didn't, you wouldn't be here today talking to me. So
thank you, much appreciated. And I tell all of my patients that Steve is on my speed dial. So unless he changes his phone number, he's not going anywhere.
Yeah, let's hope he doesn't change his number because he's on my speed dial too. So what is the research interest that has you curious these days? I know we've posted in our announcement here that you're collecting information, survey data from patients so that you can evaluate how COVID is impacting different aspects of the cardiology community. Why don't you tell us a little bit about that?
Yeah. So, when we started essentially with the pandemic, and when the pandemic essentially arrived to the United States in early March, the question was on everybody's mind, especially all of our patients had the same question: am I at an increased risk? And if you go into any website that has anything to do with essentially, medicine or the pandemic, they say that anybody with cardiac disease is an at-risk individual, irrespective of their age, irrespective of how they're doing.
Right.
And so, in general, we agree with this, and this is our essentially recommendation to everybody that they should consider themselves as at risk. But from a biological standpoint, it doesn't make a lot of sense that if you have a fit cardiopulmonary system, even though you have a lesion inside your heart, or you have a mutation, or you inherit something, but if you have a fit cardiorespiratory system, is it truly independent of age and other comorbidities that you are at risk? And so that essentially led us to creating this survey. The survey essentially is approved by our local IRB, which is essentially the body that oversees all the research that we do. And it's a short survey, it's less than 10 minutes, and it's designed for anybody with any heart disease, irrespective of having HCM or not. HCM is part of the survey, but we wanted essentially to capture everybody who, and also irrespective of their COVID testing status. Because the more you collect data about everybody in the community, the more that you understand what's happening to these patients. And so, the CDC helps us in collecting data about those who are infected, those who essentially die, and those who recover, as well as the characteristics of inpatients, so patients who are inside the hospital. But what we don't know is, all the series have shown that those who are obese, who have hypertension, who have diabetes, who are older are at risk, and at risk of essentially adverse outcomes also. But what we don't know is, but what's the percentage outside in the community of people who have maybe similar problems and they're doing well, despite essentially being infected or not? And so essentially this is how, this survey came around, is that, we can combine the information that we get from the survey from the community, and then look at the information that is published by the CDC and other agencies, and just try to understand the fractions in each of them.
But we need to know from the population who is affected with these other diseases like HCM, amyloid, transplant. I completed your survey as a transplant patient. So we need to understand how it affects everybody. I don't necessarily know that we're going to get great answers for what to do next month, but I don't think this virus is going away that quickly. And ones like it might show up in the future. And the more data we have on how these diseases impact our body, the better we can prepare ourselves. The HCMA went out at the beginning of March with a statement on what patients with HCM should know, which was, we knew a tiny bit of what they should know, but that data is growing literally by the day, by real life experiences. I'm happy to say that we have had a handful of patients with HCM develop COVID symptoms and have recovered very well and are doing great today. So we're not seeing this catastrophic effect from the virus in everybody, but I'm sure there will be some people who are more affected than others. So we need to really get some data there. So everybody has the link. It's right here on the whether it's above or below us right now, I'm not sure. So you can just click on that link and take the survey. It's also elsewhere on the Facebook page. And if you get the HCMA newsletter, you can get it from there as well. We have some comments coming in from all around the world right now, it seems. Let's see. I'm going to go back to the beginning. And you have a hello from South Africa. You have a hello from Colorado and Oregon. You got some locals there in the UK. You got, Kelly's going to pop in here. Lucky to be a patient of OSHU. You're welcome. I've known Kelly for a really long time now. She lives up in Alaska. But look, we've got this for you now. We've got somebody who knows as well. Unfortunately, the track isn't working on here, so you can't read the whole comment, but she is feeling so much better knowing that there's somebody there to take care of her. So we have some COVID comments. I'm not sure what ones are. I don't know what that means. I'm sorry. I took that out of context here. And Diane, yes, data is critically important to our knowledge in the future. So
let me just comment on that comment about COVID leaving the hospitals. I think it's an important point that people need to understand. It's unfortunate that we are fortunate that, for example, in Oregon, we don't have a lot of COVID deaths and infections. But we have to keep in mind that having essentially a hospital with patients who have COVID does not mean that if you as a patient, if you get sick, you shouldn't essentially just stay, it might be okay to stay home, but you should essentially inform your physicians of what is happening. Don't essentially make the determination yourself that, well, there is COVID everywhere, I'm not going outside of my house. The reasoning behind that is if you look at New York and other affected states, as well as Italy and Spain, the rate of outside of the hospital deaths for presumably non-COVID related deaths have increased tremendously over the last month or two. And the main reason is because patients are not seeking medical care when they're supposed to, because essentially they are afraid of catching the virus. And so we're not suggesting that you should go to the emergency room, no, but I'm suggesting that if you develop new symptoms or if you feel something that is not right, you should reach out to your physicians immediately, because there are pathways to taking care of these things that do not necessarily overlap with patients who are sick from COVID.
Absolutely. So Carrie has a question in the COVID stream of things. So as some parts of the country start opening up, I'm going to comment on the word afraid to go out in public, or you should just stay in a little bit longer. I think anything outdoors with lots of people is going to remain a little frightening for a while. And I think that when they say things are open, that everybody should move slowly and still use protection. Still keep your social distance. Don't stand in big crowds of people. This virus is going to be around for a while. And you might catch it and be an asymptomatic person, or you may be an intensive care treatment person. Unfortunately, a girl who works in my hair salon lost her husband early this morning to COVID. Just completely random, no underlying conditions that we know of really, but it can happen. So please be careful about going back out into public. You want to comment on that?
Yeah, absolutely. I think there are two points here. One is, even for states who have shelter-in-place regulations, you are still allowed to go out and exercise and walk around, and we do encourage these things. But you have to avoid crowds. If there's a park that is full of people, just choose a park that no one likes and go and walk in it. So that's one. The second thing is, we are talking about opening the country again, but in reality that we've never closed down completely. Some countries have military curfews in place. We don't have that. We are relying on people to do what the experts are recommending. And essentially, there's going to be a series of actions probably over the next month or so taken that we are, gradually trying to, and is as an experiment, gradually trying to open up things. But I would say for patients with heart disease and patients with HCM, I think you should be extra cautious. I think if we end up saying, okay, so now we're gonna, do the first series of, openings for certain sectors, I think patients with heart disease should wait a little bit until we learn more. And we should learn from other countries. You have Japan, you have Singapore, who essentially opened up a little bit in the last couple of weeks, and we're seeing essentially surges there. And so my recommendation is to learn from others. And so just look at what happens as we open slowly things up, and then then things could apply to patients with HCM after that.
Okay, that's really helpful. This next question has me a little confused. So thank you. Same to you. My cardiologist is waiting for the balloon they need to do the procedure, having an ASA, even though we're in lockdown. I'm truly hoping that this person has consulted with the Center of Excellence to go ahead with an alcohol septal ablation in this time to make sure that it's actually the right procedure, because it's right for a small number of people when myectomy and medication are right for a very large number of people. So the thing that has me a little concerned there is waiting for the balloon. If they don't have the equipment in-house, I'm wondering what experience level they might have with the procedure. And, I'm going to take this opportunity to comment or have Dr. comment for us on why high volume care matters in HCM. You want to talk about a novice versus an expert?
Sure. It's really hard to comment on that comment because, we don't know the specifics and whatnot. In general, I can tell you that probably there is no urgent indication to treat, the obstruction in hypertrophic cardiomyopathy. And when I say urgent, meaning it's something that has to be done within the next couple of days. And we talk about these procedures as being time sensitive. They need to be done, but they don't need to be done essentially in an urgent fashion, because you have to remember there is always a risk of requiring so you have to stay in the hospital, you might end up staying in the ICU, and there is also a risk of going into heart block, where then you need a second procedure, which is a pacemaker. And so essentially these are the things to consider. Now, in terms of the volume situation, it's been shown tens of times over and over that a low volume center, it doesn't have to do with necessarily the expertise only. It's just the fact that, when you do something repeatedly every couple of weeks is different than when you do a couple a year. And it's been shown essentially in publications on, all the procedures, including septal myectomy, that the outcomes of patients are, magnitude better if they are done at high volume centers with specialized team approach and multidisciplinary team approach, as compared to essentially sporadic cases that gets done. And with keeping that in mind, our recommendation always to everybody to essentially always seek a center where essentially Center of Excellence, and a center where they actually are doing good volume and they have specific individuals who do these procedures.
So in addition to that, I'll say patient selection is probably the number one factor to determine who's going to have a good outcome from alcohol septal ablation specifically. And you need sometimes a team approach. I like to say, in kind of Jersey terms, I like to see y'all fight over what you think is right for a patient as a team of HCM experts, because y'all have points of view that are valid. But when you all collectively get together and make decisions for the patient and present them that we believe that this is in your best interest versus that, is a very different kind of presentation than a patient would get by just going to a surgeon and hearing just from the surgeon, or just from an interventional cardiologist, who are the ones that actually do the alcohol septal ablations, or just going to an EP. Because we need the electrophysiologist, we need the understanding from the surgeon and the physiology of your heart. We need the internal interventionalist to give us comments on what they think is best. And then we need what I like to call the map makers, which are people like you, which are imagers who are looking at the anatomy and saying, you know what? No matter what we do with alcohol, that mitral valve is still going to come back and create that obstruction. So I really don't feel, from a map maker's point of view, from an imager's point of view, that this is going to be best for that individual patient, which is why we really recommend the Center of Excellence approach, which has worked for thousands of patients now for over 20 years. So just take that opportunity to, get on my soapbox.
Yeah. The other point, excellent points. And the other one to add is, the hypertrophic cardiomyopathy physician who sees essentially 10 patients a week or 20 patients a week end up also following these patients after their procedures. And for each essentially site, that physician essentially would know how people behave and do over time. And so it's not just a snapshot of those 30 or 60 days peri-procedural snapshot. You have an idea of what's happening over time, and you know what works best for your place, center, and essentially you should be also knowing when to refer out. For example, if you think that something essentially is essentially interesting or unusual or requires a specific approach that's only like one or two surgeons do, then there is no essentially shame in that. On the contrary, our goal is always the patient and the best interest of the patient, and that essentially should remain essentially the focus when we do any of these procedures.
I think the problem that a lot of people come into, and we at the HCMA understand this very well, the best person for you may not be the guy in the next town. It may be 2 states away or 3 states away, which does add to some level of complication in getting procedures done. But if you think about it this way, a lot of people are willing to, in normal times, get on a plane and go to Disney World and spend a week with a mouse. And that has a cost associated with it and an element that enhances your life. Well, maybe you should be taking a plane trip to a center of excellence in a hospital that suits your needs better than going to visit a mouse. And you do have to make decisions for what's right for you and your family and your long-term success. I'm going to pivot here to another question that Sandra brought up. So I'm sorry, wrong question I was going to. Somebody asked about clinical trials. And I lost that question for a moment. Sandra, we'll get to yours in a moment. But can you tell us what's under evaluation right now in a true clinical trial and what the status of clinical trials are during COVID?
Yeah, excellent point. So clinical trials are actually classified into 3 or 4 categories based on what you're actually doing inside the trial. So there has been a lot of changes because of COVID, but for patients who are actively receiving an investigational drug or a placebo in a trial where essentially there is need for monitoring and there is harm in discontinuing the trial, we are actually still continuing with the trial, seeing patients essentially as I talked about our modified operations, we are seeing our patients essentially with our modified operations in a separate essentially clinic from the hospital, and we take all precautions needed so that they don't essentially get exposed to anybody who is essentially either high risk or infected. And so right now we have as you're well aware, there is the mavacamten, which is was the first essentially myosin inhibitor to be tested in patients with hypertrophic cardiomyopathy. So the Explorer trial, which is the phase 3 trial that essentially is going to give us the answer about mavacamten, and hopefully it will be good, and they would go to the FDA with it, is just concluded the trial itself. But there are essentially all the trials for mavacamten, all the patients who have ever been in a trial with mavacamten, they are on something called open label extension, which is essentially once you finish your trial as a patient, you are rolled over to this extension study where you get the active medication. Everybody gets the active medication. And so we have a lot of patients on, not actively enrolling patients, but we have a lot of patients who are continuing on the medication. And these patients are still getting their safety assessments and safety evaluations with us, with an echocardiogram, with blood work, because we feel that the risk of not doing so outweighs essentially the risk of COVID in that specific scenario. And in terms of new and ongoing clinical trials that our patients can consider and can think about essentially joining, we have essentially a new trial called HCM Redwood, and it is sponsored by Cytokinetics, and it's essentially a second generation of the same, of the molecule, which is a myosin inhibitor. And this is a phase 2 trial. Just essentially for those who don't know, so phase 1 trial is a trial that gets done in healthy individuals, and it shows that typically that what dose you want to pick and the safety of those doses. And then you move to the phase 2 trial where you are essentially you put patients essentially not knowing, it's a blinded study on the medication, the active medication, or a sugar essentially pill or equivalent of a sugar pill, where you essentially study the safety of the medication and its potential effectiveness in a small group of individuals. And if the phase 2 is good, then you move on to the big trial, the phase 3 trial, the regulatory trial that essentially gets the medication hopefully either approved or essentially whatnot. And so we started enrolling in HCM Redwood. We were the first site in the world to enroll in the HCM Redwood. Our first patient was enrolled in February, and so far we have 3 patients, enrolled for the trial. It's a short trial; it's only 14 weeks long, and and for the last week or 2 weeks, there's been a hold on screening new patients, which is understandable. In the era of COVID, you want to be careful that if somebody is not already on the trial, you might want to push it for a couple of weeks to months before you put them on the trial. So for now, we have a couple of weeks hold, but we are going on this on a week by week basis, and we still continue to screen our patients, meaning something called pre-screen. So when I see a new referral in the clinic or a patient follow-up in the clinic, I would tell them about the trial. I would say that we have this exciting opportunity. It's closed for now on pause, but it's going to reopen again. And, we give them the consent form, we chat about the trial, and then we reach back to them, later when the trial opens up again.
So for anybody who wants to know a little bit more about clinical trials, if they go to 4hcm.org and then click on the clinical trial tab, we have a filter called Antidote, and you can put in your information. It'll ask you a couple things. It is focused on hypertrophic cardiomyopathy for obvious reasons, and it'll tell you where the clinical trials are available. There are currently several open around the country right now. The very interesting thing to this community is you've got 2 different companies now coming up with clinical trials. Okay. One is myocardia, the other is Cytokinetics. There are some other drugs being investigated right now I'll talk about in a second. But what's really, really interesting about myocardia and Cytokinetics is the molecules that they're looking at, meaning the drugs that they're looking to develop, are very similar in mechanism. So if 2 companies are putting all this effort into a drug trials, going down the same pathway because they think they have found a target point, that's really encouraging. That means we're really synthesizing down and getting to a mechanism point. And we're going to start talking about meds in different ways. We're used to beta blockers, calcium channel blockers, diuretics. That's our kind of mainstay, maybe some antiarrhythmics. But these medications are actually more focused on cardioenergetics. How does the heart get energy and how does it release energy? And how does that mechanism engage? And that's a whole new ballgame, people. We never thought about heart medicines like this before. So this is really interesting times, and I'm excited about it personally. So I would encourage you to get more involved. Look up a trial in your area, whether it's if you're in the Oregon area, that's great. There's going to be sites around the country and around the world. Somebody asked about Centers of Excellence in Brazil. I just want to comment back that I don't have any connections right now in that region. I'm looking for some partners in South America right now. So stay tuned. And when I get more info, you'll get more info. Somebody asked about multiple myectomies. And I'm going to let you take this one. How often do you see patients with HCM have multiple myectomies?
It does happen, but it's on the rare side. And this is part of the reason why we say you have to go to a high volume center. Because, the first question that one should ask is, does the heart grow back again, or just simply the myectomy was inadequate or not enough, or something happened that the surgeon was unable to essentially, shave all that septum? So that's one. 2, is the mechanism of obstruction still the septum, or was the mitral valve left alone and the papillary muscles, which are these attachments under the valve, were left alone, and those might be the essentially mechanism for the obstruction? And so it's a very difficult question to answer, with a simple, one sentence answer. But the bottom line is actually it's pretty uncommon to redo isolated septal myectomy just for the septum, because essentially you just take that piece out, and if you confirm that your results were good immediately after the surgery, it's very uncommon to require another one again. However, if you look at large series that we've worked on before, for example, one from Cleveland, when I was there is still a small percentage of people over about 10 to 15 years of follow-up, they do develop obstruction again. And again, the issue is you never have access to these old records. So these surgeries that were done in the 80s and 90s, we don't know exactly what was done there. Surgical techniques have changed. our way of studying the heart have changed. We have now MRIs in everybody. Our evaluation for the mitral valve has changed over time. And so the simple answer is it's very uncommon, but it's complex and needs to be essentially evaluated really carefully of why we're thinking about the second open heart surgery in somebody.
So I'm going to add to that, and I'm going to say I've been running the HCMA now for 24 years. I've seen a lot of things, and I've seen a lot of people go to surgery. If you go to a surgeon who is lower volume, they have a tendency to take less muscle because it's scary to take out heart muscle, even for a cardiac surgeon. So they tended to do a minimal myectomy, and then it tends to have a residual gradient, which over time may get worse, and those people more likely go off for a second surgery. But the other thing that I think is critical is even when you go to the best surgeons, and I know a couple of myectomies that had to be redone from our top 4 programs in the country. When you take out muscle, you'd be a little naive to think it didn't have any other consequence because that muscle had pull. So if you took out a hunk of muscle and now the heart is torquing in a slightly different direction, just because the geometry of the ventricle has now changed, that might have a downstream consequence that might create obstruction in a slightly different point. It's very rare. Have I seen it happen? Yeah. Am I surprised by it every freaking time because the results look good up front? But sometimes they can come back. I am aware of some handful of people who've had 3 myectomies. The first one I think was a complete waste of time in every case because you go back and you look at the pre and the post. The second one was maybe not optimal, and the third one was the charm. So those are rare situations. And I want to double back to the alcohol ablation comment. If a patient goes to an alcohol ablation thinking it's the easy way out because it's a catheter-based procedure and they don't need to have one of these funky thoracotomy scars afterwards, I have a good scar. I love my scar. But if they have an alcohol ablation thinking that's the easy way out, they always create or almost all the time, create a right bundle branch block, which is in the conduction system. And when they go to a myectomy, they almost all the time create a left bundle branch block. That means if your alcohol ablation fails and you have to go on to surgery, you're buying yourself a pacemaker for the rest of your life in almost all the cases. Not 100%, but darn close. So again, that team matters. I don't know how many of those cases that you've seen that have come back after an alcohol ablation and gone in for surgery. But
so our approach is different than Europe in general. In Europe, alcohol septal ablation is very popular, and it is offered as a first-line therapy in a lot of centers. Our approach here in the U.S., and I'm going to talk specifically about Oregon, is OHSU. Is we actually prefer doing myectomies on patients because you can address the whole disease spectrum and not just essentially address a single point in time. And when you're going into an alcohol septal ablation, you are able to study the territory that you're going to be essentially inducing an infarction in, but you actually don't know the ultimate results. You are trying something out. This is more controlled when it comes to myectomy. So for us, essentially, we reserve alcohol septal ablation for patients who we consider to be high risk for septal myectomy. And it's a fine balance. Once you start tipping the scale that you might end up harming somebody more with an open heart surgery, then we go down the route of alcohol septal ablation. So we don't actually end up experiencing a lot of these situations where somebody end up with upfront alcohol septal ablation and then later septal myectomy, just because of our practice patterns and how we do it.
Well, I think you guys do it right. So that works. Do we have any other follow-up questions? We're going to wrap up here in a minute. We've had the good doctor's time for a good 45 minutes on a Saturday afternoon, which I thought was really awesome of him to offer. So while you're all sitting home in COVID days on a Saturday afternoon with no place else to go, thank you for spending your time with us. Let's see. Thanks for the updates. California here. Hello, Tim Stewart. Long time no chat. Several myectomies. We've answered that question. I think zipper scars do rock too, but I have to tell you, I got a trick, ladies and gentlemen, not just ladies. Silicone stick and bio oil. After you have your surgery, wait for the scar to go up. Treat it with some silicone stick. You can get it on Amazon. Put on bio oil. Silicone softens the scar. Bio oil takes out the redness. You don't have to throw it in everybody's face. You can have a nice little scar too. Just saying. You know, with all that was said and done, I'm still a Jersey girl who's a little vain. Wanted a little scarf after my transplant. So we did that. Okay, it looks like our questions are wrapped up now. If anybody has any questions after 3:50 p.m. Eastern time, by all means, feel free to send a note on here. We'll try to address those questions later. Doctor, thank you so much for joining us today, and we look forward to lots of great things coming from you.
Thank you. Thanks for having me, and stay safe as well as everybody. And again, thank you for having me today.
Thank you so much. Bye-bye.